scary scleritis. Presented the case of a 55-year-old female who came to us on 24th of October 2023 with complaints of eye pain and redness in the left eye of 2 weeks duration. There was associated severe left-sided headache and light intolerance. No history of any similar episodes in the past. Patient is a known hypertensive on treatment. No history of any fever, rash, joint pain, exposure to TB. No history of any trauma or ocular surgeries. On ocular examination, right eye was within normal limits. Left eye examination revealed best-corrected visual acuity of 6/18. Lid and adnexa was normal. Anterior segment examination revealed circumcorneal and diffuse scleral congestion, diffuse medium-sized pigmented keratic precipitates, 2+ cells and moderate flare. IOP was 32 and fundus was normal. Thus, a diagnosis of acute anterior uveitis with scleritis and elevated IOP was made in the left eye, and patient was started on topical steroids and mydriatics. Elevated IOP was also taken care of and she was advised uveitis workup. Preliminary investigations in the uveitis workup came out as negative except for the elevated ESR and C-reactive protein. She had not done MANTO in that visit, and since the symptoms were improving, topicals were continued. Further investigations were also negative, and then she came to us after 12 days. In that visit, IOP reduced, however, uveitis and scleritis was persisting. MANTO and quantiferon TB turned out to be positive in that visit, and she was sent for a pulmonology opinion and pulmonary tuberculosis was ruled out. Meanwhile, she also had an intolerable headache for which evaluation was done and CT came as negative. So then she presented to us after 2.5 weeks with a worsening clinical picture despite the use of topical steroids. So we started her on oral steroids. 2 days later, there was dramatic worsening of the clinical picture, vision dropped significantly to perception of hand movements, and IOP was 30. There was exudates in the anterior chamber and hyphema. So B-scan was normal. So we were in a dilemma of what next in this peculiar case of scary scleritis, and now I would request ma'am to take over.
Good morning. Thank you, Dr. Kavya. So this dramatic worsening immediately after steroids made us realize that a serious snag has occurred in this case. We have mixed and infectious etiology, probably viral, based on the high IOP and high fever. So we immediately initiated our saving efforts, stopped systemic steroids, continued with topical steroids, added anti-glaucoma medications, went ahead with AC-type for viral PCR, blood samples sent for serology, and started oral acyclovir. 5 days later, there was only marginal improvement. IOP remained high, so we added 1 more AGM. By 9 days, we could see the first sign of improvement. Fibrin has started retracting. However, IOP was still 26, so 1 more AGM was added. By then, the serology reports came, which showed a significantly elevated IgG for VZV. HSV titers are also mildly elevated. However, PCR was negative for all the 3 viruses. 2 weeks later, there was little more improvement. The fibrin had started retracting. However, this condition was persisting, and due to intolerance, brimonidine had to be stopped. By 1 month, there was further improvement. The clot had retracted further, but the condition was still persisting. B-scan at this stage showed a superior choroidals. Now we increase the topical steroids. Ideally, we should have started systemic steroids, but we wanted to be a little cautious and we just decided to wait. When the patient came, we could see that the clot had retracted almost completely, and we could see suspicious new vessels. Fundus view was better, but the B-scan showed persistent choroidals and with a low IOP. So we then added oral steroids. The next month, there was even further improvement. The clot had almost completely gone. IOP was stable at 10. So we stopped the AGM and tapered the systemic medications. By next visit, vision had improved to 612, IOP was stable, early PSC cataract was developing, and fundus was also normal. She was then lost to follow-up and came back only 9 months later. Vision has again decreased to counting fingers 3 meters, which she said is only for the last 1 month. Meanwhile, she developed diabetes, and so she discontinued all her medications. Now she has developed a total advanced cataract, and as we can see, this kind of hyperpigmentation on the iris has also resolved by now, and she was advised cataract surgery. So what did we learn from this case? Rule out an infectious etiology in any case of scleritis or uveitis before starting systemic steroids, and whenever there is an immediate worsening, it is a strong strongly suggesting an infectious component. So what are the clues to suspect infection? A very acute presentation, unilateral and disproportionate pain. If there is associated keratitis or uveitis, hyphema, hypopyon or increased IOP, these are strong indicators. And presence of purulent exudates, conjunctival ulceration or scleral abscess, these are more straightforward situation. And all such cases investigate to identify the etiologic agent either by scraping or tap or biopsy and start antimicrobial therapy, then give steroids to take care of the immune component. Thank you.
So why this TB positive mantle and quadriform gold was positive?
Yes.
So what could be the reason for that?
That
Is there combined is there any underlying TB also responsible for that?
Yes, yes. See, both
Usually will the viral uveitis aggravate even if it is infectious by systemic steroids viral?
I didn't get the question.
Viral uveitis, will it get aggravated by starting systemic steroids?
Yes, without the cover of antivirals.
Without the cover.
Yes, we should have started the antivirals first and then give steroids, which
Yes.
ultimately we did, and there was only improvement.
Or is there any combined infection along with that? Is there a TB also? Extra pulmonary?
TB being endemic in our country, it is always a possibility. But the thing is, when the pulmonologist is evaluated and said there is no need for ATT, then we cannot question it anymore.
But both quantiferon gold and mantle was positive, and
Yeah.
ESR also.
Yes, but still that is not enough. You should have a radiological evidence and a phenotype which is correlating with TB, which was not there in this case. So for the time being, we thought, and patient was not improving with topical steroids alone. So having ruled out TB and syphilis, such infections, we went ahead with systemic steroids. But the slip was, we did not think of a viral etiology at that point of time.
And initially the IOP was 32.
Yes, that was a mistake.
That
Yes.
was a mistake.
That was a mistake in this case, and that is a main learning lesson.
Yeah.
So whenever there is an initial high IOP,
At that stage, there was no much signs of inflammation also. So that
Yes.
tuberculosis was viral because of the virus.
Yes.
You have to think of
yes,
in the initial stages. of
correct,
virus.
correct. Yeah, that was a slip in this case. Thank you.
And always, I think the rubiosis might, so you should do a gonioscopy also if the pressures are definitely high, probably.
Gonioscopy was done, it was closed and nothing could be visible at that time when the patient had high IOP. And later on when the clot resolved, we could see faint new vessels on the iris. We could pick up, but it was not very, I showed that image also, but not very clear in that.
Okay. And the AC tap was when, was it sent for the TB PCR also?
TB we did not consider because it was almost sure we are dealing with a viral etiology, because such high IOP and hyphema is more common with viral rather than with TB. Thank you.
The next